Assalamu alaikum and hello. I am Faryal, and in today's segment on New Wave Global, we take up a rising global health concern to talk about superbugs or pathogens, viruses, bacteria that develop resistance to antibiotics and how they are spreading at an exponential rate globally, according to a recent report by the London-based Bureau of Investigative Journalism, which is an independent and not-for-profit organization. The research highlights the devastating effects of drug-resistant infections, claiming that around 5 million lives are lost to drug-resistant infections every year globally. And it's the poorest countries and most vulnerable populations that face the greatest risk, which is, of course, not surprising at all. Deaths due to drug-resistant infections are predicted to reach a figure of over 10 million annually by the year 2050. Pakistan is particularly vulnerable to the rise of drug-resistant bacteria due to widespread, unregulated use of antibiotics, often sold over-the-counter drugs, self-medication, just to list a few factors. A World Bank report warns that if this loss of drug effectiveness trend continues unchecked, the world will confront a reality where many infectious diseases might have no cure and no vaccines. To apprise us of the impact, joining me here is Dr. Faisal Sultan, who of course requires no introduction. He is the CEO and consultant physician of medicine and infectious diseases at the Shaukat Khanum Memorial Cancer Hospital and diplomat, American Boards of Infection Disease and Internal Medicine. Dr. Sultan has been the key figure in COVID-19 pandemic management in Pakistan. He was appointed as former Prime Minister Imran Khan's focal person on COVID-19 and has also served as Special Assistant to the Prime Minister on Health. Dr. Sultan, welcome and thank you for joining me.
Thank you very much. It's a very kind introduction.
Let's start off by referring to this research by the Bureau of Investigative Journalism, which claims to be reporting from the front line of this global antimicrobial resistance crisis. What the report covers, in fact, uncovers are disturbing first-hand narrations of what happens when drugs stop working against certain infections and medical conditions. And the report quotes multiple examples of such cases from Pakistan as well. So how would you assess the situation here in Pakistan in light of the risk which is posed by this rise in drug-resistant infections?
Thank you. I think while it is a global phenomenon, and sooner or later everybody is going to taste the difficulty of this problem and the challenges associated with it. But I think Pakistan and perhaps other developing countries, the subcontinent in particular, in some ways, have been early sufferers of the issue. But let's go back. Let's go back decades when penicillin was first found. And what became very clear, even in early days, was that as you start to deploy the drug, as you start to use it, you automatically select out through natural selection those strains of bacteria that were resistant to it. So, when penicillin came about, famously, Staphylococcus, which is bacteria, was sensitive or, nearly uniformly or largely sensitive to penicillin, plain penicillin. And then with time, it became resistant. And so newer types of penicillin had to be engineered, discovered, made to cater to that problem. So it's really, this is an old problem. It's a race between the bacteria and our ability to come out with new compounds. The problem is that with time, a number of things happen. First, global population, and the fact that the number of opportunities that each antibiotic had to face a set of bacteria, those number of opportunities increased exponentially. In other words, usage increased, the population increased. The second thing is that with time, people also discovered that other than medicinal use, it could be antibiotics could also be used to fatten animals. And so their veterinary use and poultry use went up. So not only was it being used in human circumstances, but also being fed to our food chain. And so therefore, when the food that you eat, the meat that you consume, then ends up having small traces of pathogens that may also be carrying resistance genes. Then yet another thing has added to this, which is that the global investment into antibiotics went down after a while because people felt, well, we've got a huge range of antibiotics and this should be good. And so the global investment went down. I must also point out that it is not just a modern phenomenon. There are scientific papers that describe the discovery of resistance genes in bacteria that have never had human or modern exposure. There's a very famous paper that cultured and discovered, detected, I should say, bacteria out of caverns in the US, which had never been opened in a million years. They'd had no human interaction. And yet, when sequenced or analyzed for genes, they had genes that conferred resistance to modern antibiotics that they had never seen. So it's a complex mix of problems. Then more lately, companies have come up with trying to invest into, and there has been great ventures, sometimes government driven, to have R&D for innovation and research in new antimicrobials. But interestingly, despite the fact that some newer drugs have come to the market, some have exited the market simply because they, paradoxically, while there's a huge need, they could not find a business case. And there are cases where the desire to have judicious use, which is great, but also then killed in some ways the business case for these drugs to be there. So all this has compounded us to a situation where we are. And Pakistan in particular, and especially in gram-negative resistance, other neighbors around us, other countries around us in this region are all facing very serious issues, especially in ICU patients and patients sick with a different set of diseases who are very unwell, the more vulnerable patients, cancer patients, for example, they all become at risk for these infections. So I apologize for long-winded answer, but should
that's fine. In fact, you've already covered some of the questions that I had in line for you, but that's fine. So the human use of antibiotics, according to one statistic, has risen by almost half between the year 2000 and 2018 alone. Perhaps that adds to the emergence of this phenomena a little more. Like you're saying, it has always been around, but maybe that has a little part to play as well. So on the 26th of September, 26th of this month, the UN General Assembly is convening a high-level meeting on antimicrobial resistance during its 79th session in New York. The meeting aims to negotiate a political declaration for UN member states to curb the impact of AMR, which is antimicrobial resistance, on health, environment, and development. Could you just very briefly elaborate on how the threat of superbugs impacts the environment and a country's development in particular, apart from, of course, the health cost, the factor that it raises the health cost for countries like ours in particular?
Right. So far, the common man or the average person or the average citizen has not directly faced this because in many ways, common antibiotics, when required for routine type of infections, remained effective and useful. And so this really remained a phenomenon for physicians, particularly those working in intensive care units, in cancer care units, and burn units, and people with extensive surgical procedures and so on, were confronted with this whole problem. And so while the problem was there and people like us had been flagging the issue for a number of years, it has now become front page news. This is now international mainstream news. It will impact us in a number of different ways. Many diseases, or many conditions, I should say, which have had modern medical intervention and good outcomes, are enabled by the availability of great antibiotics. And as that becomes less, your ability to do complex surgery, your ability to do transplants, your ability to do modern intensive care, burn units, and I'm just listing a few. All of these things will become very much harder to treat and manage. And some common things like typhoid, for example, we have seen such an increase in the resistance that it is now getting to the point that when you are confronted with a case of typhoid and you don't have sensitivity data yet, because it takes a few extra days for the sensitivity to arrive, you often don't know what to do other than to cover somewhat broadly in the beginning and then to narrow down the antibiotic use. And so typhoid is a common illness. And in countries that have extensive transmission of it, orofecal transmission is high, water and sanitation is not at a great point. So all of these things add up to make a common disease a very dangerous one, simply because of resistance. The other thing that it does is because of extensive use, as I mentioned, in veterinary and dairy use and so on, you end up, because that's not exposure to the healthcare system if you're unwell. Forget that. That is exposure to something that you consume every day, or potentially every day. And so therefore, once it enters the food supply, that resistance then becomes a problem for the entire population. And the ability to treat it effectively, if it goes down, then the mortality rates rise for many of these challenging healthcare conditions. And so it all has a major impact on what you do. And the other thing is, even if you do get antibiotics that are somewhat more effective against these modern, the new resistance, they're very expensive. And so they are exponentially more, expensive to purchase compared to common antibiotics. And so therefore the need and aim to conserve as much of the existing antibiotics as effective drugs is as important than as ever at the present time. And all these general assemblies and resolutions and so on are trying to address that. But it requires very major change of behavior, not only in the population, but also amongst healthcare providers. I'll give you an example. During the 2 years of COVID, the amount of some antibiotics that were used and overused is unbelievable. We tried to inform the providers and prescribers that, look, there are only certain situations in which an antibacterial medication should be used. But essentially, what is a viral infection? But there was such an emotional response to this that a lot of very well-educated physicians trained in some of the best places in the world were continuing to prescribe, for example, macrolide antibiotics indiscriminately. And so everybody is to share the burden, and I don't want to use the word blame, but the responsibility of where we are. And we can still try to turn the corner, but I'm afraid, I feel that we have passed a certain point, and that this resistance will be very difficult to undo from where we are. Okay, let's stop here. Well, we'll see what you have to say on other questions.
I would say the healthcare providers, they have that responsibility more than the layman, because people did panic at that time, and we were looking for, from wherever we could get information to take whatever we could that would help. In Pakistan, we know that health is one of the most neglected areas in terms of policy priority, fund allocations, and our health budgets bear witness to that. Now, while other high-risk poor countries, like in the same report, I was reading that Kenya and Nigeria, because they were the other two countries in addition to Pakistan, whose examples they had included in the report, they have adopted national AMR surveillance networks to counter most urgent public health challenge. Now, considering that in Pakistan, we are still grappling with the basics, and despite an extensive public sector health infrastructure, our health system suffers from chronic underfunding, we've got corruption, we've got impact of an unstable political environment. Do we have the margin or capacity in our health system to attend to this rise of this, like you're saying, this is front page news now, this is imminent, as it has been posed, and how do you think we will go about
Right. So our bandwidth for tackling things is not small. And I always refer to the COVID example. When it all started out, there was a lot of disbelief and a lot of pessimism or lack of confidence, I should say, in our health system to be able to respond and react to it in an effective way. And yet it did, both in terms of treatment, or in terms of contact tracing, in terms of vaccination, in terms of so many other interventions that were required for the day. And it was our health system, the same health system that we also berate. And so I think we do have the capability, but there are things that work against us a bit. One is our size and our very, very devolved system of healthcare. Now, a large country like ours cannot have a central delivery of healthcare. That goes without saying. There's no argument there. But for a lot of public health interventions, cohesion, synergy, synchrony is required between provinces and the federating entities. And had we not had that synchrony during COVID, we would have suffered more than we did. And perhaps some of the examples globally from large federal structured countries should serve us, should remind us. So it is very important to have central national entities that are able to review, guide, provide professional guidance and cohesion to such things that really cut across all boundaries. And AMR is certainly one of those situations. The National Institute of Health in Islamabad, the law was amended to include better governance, but also to include the Center for Disease Control in it, and a National Health Laboratory was to be upgraded, and a National Health Data Center. All of this was to make sure that those conditions or diseases or situations that require this collaborative work of having that information and then to analyze this and to give back the guidance and have the credibility and the authority, if I could use the word, of providing authoritative, scientific, grounded information instead of nonsense. So this sort of thing gets to be very important. And so while surveillance is one bit, without action, I'm afraid surveillance will, only remain to scare people, but not have any action. So action is very important. And I think the action has to happen not just in fields that are easy. So, the famous example, you lose your keys in the dark, but you're looking for them under the light. And somebody says, why are you looking here? Because this is light here. Well, because you lost them elsewhere. So sometimes it is important to do the harder work. So while surveillance and information is fine, the harder work is to bring action or bring light, if I could say, to where the problem is. And that includes inappropriate prescribing. And it's a very complex issue. It's got economics in it, and it's got other aspects to it. So that's a whole other interview. But the other thing, of course, is that in order to bring that action, we also have to look at the quantum of the problem in other sectors. So we cannot ignore the veterinary sector, and to not touch it and to not address it will mean that we are only, cutting at the edges. You're really not getting to the core of the problem.
That has a big role to play, because again, I was going through a WHO report, and it said that the meat industry is responsible for almost 73% of global antibiotic use. But the meat industry is under little pressure to wean itself off this overuse of medicines. And I'm sure this holds more true in our case, where there are no checks in Pakistan, no regulations.
That's right. That's the point I was trying to make, that if you calculate in tonnage terms or kilograms terms, in some antibiotics, the majority of use is in the veterinary sector, in the non-human sector. So you could keep screaming and going blue in the face for antimicrobial stewardship in the in the clinical scenarios, and that's good to do. But then if you don't address this other thing, you could constantly have influx of resistance. The other thing to remember is that bacteria are clever in this way. And it's evolution, it's nothing strange. Once they come across a gene that helped them survive an antibiotic, they hold on to it by and large. And so when exposed to that antibiotic again, it'll come to the forefront again as far as the bacteria are concerned. So in a way, it's kind of a one-way street. Once resistance is out, then the genie is out of the bottle. You cannot put it back in. There are other things around the corner, including newer techniques and newer approaches to how bacteria have to be tackled. And mind you, it's not just bacteria, as you mentioned in your opening statement. It's other things, fungi, so fungal infections, similar problem. Even for viruses, there are well-documented resistance for certain kinds of viruses, for certain kinds of antiviral medications. So overuse will sooner or later bring resistance.
So are these antibiotics also used in farming practices? I mean, the vegetables that we eat, the fruits that we eat, are we also susceptible through this type of consumption?
So all these roots, if they get contaminated or inducted with chemicals that are either antibiotics or look like antibiotics as far as bacteria are concerned, do hold the same potential. But quantum-wise, I think our bigger problem right now is the meat industry.
Right. But in the case of vegetables and fruits, we eat them raw mostly. I mean, not all of them, but raw. But does that increase the chance of?
Generally, look, in case of vegetables and fruits, so non animal sources of food, while they can be contaminated and frequently do, there are so many reports of one kind of eatable product, non-meat, that gets contaminated and then causes outbreaks. All that happens. But I think in terms of the sheer quantum of what is going on and the resistance to bacteria that survive in other mammals, for example. So some biology is also at play here. A lot of plant microorganisms, they may be lethal to plants, may not be automatically transmitted as pathogens to humans. Generally, we are more likely to be susceptible to pathogens that infect other mammals or other higher organisms. And so therefore, the issue of meat remains a little bit more in the forefront. But, this is a changing scene as well, because as our global supplies also become intermixed and intertwined, and the practices of how we process them is concerned, all those also add to the risk. I mentioned the number of outbreaks, and every year you have a few, and the Western world publishes this more because they detect more. But I'll look at US data every now and then. They'll say, this vegetable or this fresh produce from that place. I'm deliberately not naming because the object is not to focus on one country or the other. Coming from this country or that country has caused this outbreak or that outbreak, and of course they recall those, and so on. So those are there. But in the context of resistance, I think the bigger issue remains what I mentioned. The other thing that we have to consider is that how food processing and handling has changed also matters. A classic example is that meat, which is in the form of, as meat, as flesh, coming out of a single animal is likely to carry X number of organisms, and they belong to that particular animal that was sacrificed to create that food supply for us or meat supply. But for things, for example, like ground meat, meat's added up from a number of different animals in the end, because this is how the process is. And so that then allows sourcing, if I could use that word, of microorganisms from more than one animal, and times dozens and times hundreds. And so the statistical likelihood of getting infections also goes up because of some of this central processing of meat. So these are complex issues, and really,
Yeah.
I'm no expert at that end of things. I'm really, unfortunately, sitting where the end result arrives, and that unfortunately is not present. It is not pretty and present right now.
Okay, so Dr. Sultan, why can't we make new antibiotics when these superbugs, by we, I mean the world, these superbugs, they develop resistance, they become invincible against the ones already in use? Because I was reading again that the last antibiotic class that successfully made its way into the market was discovered as far back as the year 1987. And since then, we've had a discovery void.
Yeah.
Why is that
So,
so?
so the pipeline kind of famously dried up, and fewer and fewer new products came out. What ended up happening is that you had set one chemical class of drugs, and people just kept modifying various, side chains and various modifications to its chemical structure, and so kept selling it. And so sometimes with modifications, it confers additional coverage. It becomes stronger, better with a bigger spectrum and all that, and that's good. But outright new classes of drugs have been few and far between. Then, about a decade or more ago, the U.S. President's office also initiated this, this challenge, this plan of tackling this. The AMR report from the U.S. White House, if I'm not mistaken, came out during President Obama's time, and there's a whole plan of course, having, amongst other things, having newer antibiotics, and so the industry did respond, as I said. But then the industry cannot be making the for-profit industry cannot be making new molecules and new drugs for just public good. They are in it for obviously a return of investment to their investors. So if the business case is not there, and if the reach of these antibiotics is not large enough to justify them to be viable commercially, then in some cases, companies have either folded or withdrawn products, and so that has been part of the thing. So it's not just the technical innovation side of it, it is also the business side of it. There are other aspects which relates somehow to the business side, as I'll explain. So for example, if you produce a new compound, say for treating blood pressure, just as an example, or for treating some other condition, say cancer, it has a certain number of years before a newer drug will supplant it, or the new kid on the block will come out and knock down the old faithful drug and say, okay, now I'm better. And so the company that has invested in it has X number of years to be able to recoup their profits and so on. Here, what ends up happening is that the drug does not get knocked out by a new kid on the block. The drug gets knocked out by the bacteria, and that's done sooner than what a new drug or a new compound would do. So here, the viable life or the viable time span of a new product is by definition a little bit smaller, and therefore the business case for investing in it also goes away. So, and paradoxically, because that time span, instead of say 10 years or 15 years, is say 5 years or 7 years. I'm just making these numbers up, but they're shorter, and therefore the companies end up saying, well, okay, we have only this many years to recoup our investment into it, the R&D costs and profit. And so they end up being more expensive. They end up being more expensive. Fewer entities can afford it, not the rest of the world. Maybe more industrialized economies can have access to some of the newer antibiotics, but the other countries don't. And so therefore, they're not viable. And so many times they do fold up. So I'm oversimplifying,
Yeah.
but some of this kind of economic challenge of how these are priced and distributed has also played a role. Some of it has also been through well-meaning efforts, but then with unintended consequences. So when a new drug arrives, and it's really a super drug for this thing or that thing, the guardians of that, they tend to use these as reserve drugs, or as those to be only used in special circumstances. That is correct. But then that automatically also further reduces its use. And again, it hits into the same issue of them not remaining viable. The other thing that is going to happen, I think, is that maybe completely newer approaches, perhaps using artificial intelligence, to design molecules that are more likely to work and succeed and be a little resistant to resistance forming. So in other words, I mean, their walls will be higher in terms of the attack from the bacteria in terms of resistance would be possible. That is also something that I suspect will happen in the future. So it's all not all doom and gloom. There is possibilities, but it'll be challenging. And for the present time, it's very challenging.
Totally understandable. And thank you very much for such a detailed reply. So for the benefit of our viewers, I know you've covered a lot of things. If you could just briefly tell us what precautionary measures to take to avoid drug-resistant infections and illnesses. We need to do awareness raising, particularly in reference to the common cold, and the flu. We are constantly told, don't take antibiotics. They are not going to work. Common cold and flu will take its time. We hear it all the time. And yet people do take antibiotics, particularly if the fever is running very high. I don't really want you to go into the medical details of all that, but are these such practices harmful? Do they have their side effects, and do they stimulate development of antimicrobial resistance?
Yes, they do. And so personal examples are terrible, but I'll give you one because it just illustrates the thing. My two kids growing up in their entire youth, they each received an antibiotic once till the age of say 18 or 20, just one each. And people are shocked and say, how come, and a lot of kids get it. And I said, well, because for most part, for most situations, they do not require these. Most of these cold and flu type symptoms require only symptomatic care. And only if true bacterial infection ensues or is suspected or is in a site that is very dangerous, only then you should be using antibiotics. Antibacterial agents are not antiviral agents. And yet, I cannot tell you how hard it is even to work with fully qualified physicians and specialists who insist sometimes on using, forget anyone else, on their own family members. So I think some of it is education and understanding the challenge. So what are the steps? Number one, reduce inappropriate use. Do not take antibiotics for every cold and flu that you get. Number two, I think our exposure to more resistant organisms particularly occurs in the healthcare setting. So when you go to a hospital, do ask what their infection rates are. Do ask that if a surgery has to happen, will they be using prolonged and unnecessary perioperative antibiotics? Prolonged and unnecessary. A dose or two, depending on the surgery, is certainly required for most situations. But beyond that is unnecessary. How are they able to prevent infection from one patient to the other? Always a challenge in hospitals, but that also has to be weighed in. And obviously, the entire issue of diet. I think so long as we retain a varied diet that comes from a range of sources, and to not just only be eating processing. I mean, those things impact on health in general, but perhaps would also be important here. I also think that other than reduction of unnecessary antibiotic exposure through unnecessary prescriptions or use or self-use, and of course, infection control, there are other principles of hygiene that also apply. And we tend to sometimes forget, the oral hygiene, for example, dental hygiene is so important in protecting us from the intake, because the mouth is remember, the mouth and the respiratory tract are the major ports of entry for many of these organisms. Appropriate cleanliness, appropriate bathing, and so on. Just general principles of hygiene are important. I would also say that while clean water is important, at times I feel that it's now a global obsession almost with sterile water drinking is also perhaps counterproductive, but that's another topic. And I'll not say more here. We can discuss it another time if you wish.
That's like enlisting a lot of them, and I'm sure if we follow them, that they'll be really useful. And uh, although there is an urgent need to limit the inappropriate use of antibiotics, like Dr. Faisal just pointed out, there's inequity here too, so that more lives are lost because of lack of access to life-saving antibiotics that due to their overuse. We need to recognize that the health of humans, domestic and wild animals, like Dr. Sultan just pointed out, the meat industry, the dairy, the plants, the wider environment, we are all closely linked and interdependent. We survive as one huge ecosystem, a bubble of life that would be jeopardized even if one life form is disturbed. Dr. Faisal Sultan, I really appreciate your very informative and useful insights. Thank you once again. Till next time, Allah Hafiz and goodbye.